Thank you very much to the panelists for that conversation. I'm not going to lie, I know I'm a novice, but I really thought cat modeling was going to be a different portion of today's event. I know that that's something else now, I guess. At this time, I'd like to welcome up our next guest. We've talked a lot about modeling, mitigation. We've looked at climate. We've looked at a lot of different aspects of this conversation, but our next topic of discussion is a really critical one. We're going to look at the health impacts of climate change and insurance solutions. We're going to talk about how climate risk is reshaping health insurance and public health strategies. And to help us do that with our next panel, please help me welcome Dr. Manisha Juthani, the Commissioner of Connecticut's Department of Public Health. Thank you.
Hi, Jen, Maureen, really nice to meet you. Nice to see you.
Hello?
All right. Boys and girls separate?
Yeah, apparently.
Oh.
I don't think it
It's not so like.
doesn't.
We have a full panel.
I think so.
Looks like we've got everybody. Right. So let me just see. So you're Marie. Tell me your name again. Tell me your name again. David, right? And Matt? Yes?
Adam.
Yeah, thank you. Okay. Okay, well, good afternoon, everybody. I'm Dr. Manisha Juthani. I'm the Commissioner of the Connecticut Department of Public Health. And this is a great opportunity for us to really discuss the health impacts of climate change and insurance. So to frame out this topic for you from the perspective of the health department in the state, for all of us, we are well aware of changes that have been happening in climate and its impact on health for quite some time. Whether it be looking at air quality when there are wildfires on the West Coast and we see impacts directly in our own state, to seeing increases in vectors, new pathogens in the state, a whole list of infectious pathogens that you can think of, from anaplasmosis, babesiosis, ehrlichiosis, malaria in Florida, dengue in Florida, all of these pathogens moving up the eastern seaboard, to pathogens like Vibrio that's in the water, and when we've had warmer water, people having more infections. In 2024, we had infections in North Carolina, in New York, Connecticut, to the impacts we see in asthma rates in our kids, even in adults, attacks, particularly as I mentioned with wildfires, where we see increases in hospitalizations, increases in emergency department visits. These are all things we see in real time on a regular basis and that we monitor as a health department. And as a health department, we don't have the levers to reduce greenhouse gas emissions, to do the things that might be able to change the trajectory of those health impacts. What we can do is advise people. We can put out advisories and educational material so that people can make those decisions in real time. For example, when we had those problems with wildfires and we were seeing kids under the age of 6 showing up in emergency departments more often, we did partner with our early childhood partners to say maybe this is a day that the kids should not be playing outside and we should just keep the kids inside today. Those are the types of real world impacts that we are seeing every day as a health department, which is why we have an Office of Climate and Health, and we really look to partner with people throughout the state as it relates to these impacts. And we have a really fantastic group of panelists here today that are going to share their perspectives from each of their viewpoints in terms of this topic. And I want to give each of them about a minute to introduce themselves. And I'll start right next to me with Marie.
Thank you so much. Good afternoon, everyone. I'm Marie Grant. I'm Insurance Commissioner for the state of Maryland. I'm coming up on a year in the role tomorrow. And prior to that, I was actually Assistant Secretary for Health Policy at our State Department of Health in Maryland, which is a super agency. It handles public health for the state, as well as the Medicaid program, as well as behavioral health and developmental disabilities. So I speak a couple of languages. I speak insurance and I speak public health. And I just, the perspective I bring to insurance regulation is that, understand the product and insurance, but also we can't lose sight of the fact that these are products that impact people's lives, and it's really about ensuring the risk of people, right? So really looking forward to the discussion today.
Thank you.
Hi, I'm David Rabinowitz from the Deloitte team. I've got the privilege of leading our healthcare sustainability efforts in the US as well as in a number of global markets. We've taken a very broad vantage point for what sustainability means, especially in healthcare. It's not only the emissions that healthcare providers, health plans, other health-related companies produce, but it's really, and more increasingly, I think the point of this panel, what is the impact of climate, of other social, other economic, other environmental needs on the health of people, on families and communities, both from a quality perspective, but also increasingly from a cost of care standpoint. I always start with what do we actually need to be healthy, and it's not just healthcare. It's jobs, it's food, it's clean water, it's clean air, it's information and agency. And so really making sure we're taking kind of the broadest possible view of what do we need to create those conditions necessary for everyone's health and well-being.
Great. Good afternoon, everyone. I'm Jennifer Wang. I'm the Executive Director at the Yale Center on Climate Change and Health. It's a pleasure to be here. I'm not sure that I speak the insurance language, so I'm very glad to be learning with the audience here and really connecting with you all. I think it's incredibly important to have this health and climate and insurance connection. Our center works transdisciplinarily across Yale and with external partners on research, education, and policy and practice, really focusing on the health impacts of climate change and the health benefits of climate action. I think a lot of the themes that we are seeing today around thinking upstream, looking at prevention and mitigation are all things that we look at from the perspective of health impacts, especially protecting the most vulnerable. Thank you.
And I'm Adam Seidner. I'm Chief Medical Officer at the Hartford Insurance Company. I am board certified occupational environmental medicine doctor and really focused on individuals. So we talked about resiliency. I'm looking at resiliency of individuals and populations as opposed to property and the environment. And so with that, I helped the Hartford get answers to some major questions that they have and the industry has. And so we do quite a bit of research and build alliances with a number of organizations, which I'll mention a few throughout the course of today, to really help our customers, the employers, as well as the individuals through some of these climate exposures.
So thank you for that. I think where we want to start right now is just starting with framing out what some of the most pressing health impacts from climate change are right now, and what evidence is really emerging to show us what that is. And so I thought we could start with Jennifer, if you will, to just sort of give us your perspective as somebody who studies this all the time, what you see the most pressing impacts.
Thank you, Commissioner. And you've already mentioned some of those impacts that we're seeing here in Connecticut. I just want to maybe take one step back and say that in terms of climate, the climate reality is that we are living in a perilous time. I don't think that anyone of us would argue against that, but I just want to say for the record, 10 of the hottest years since 1850 have occurred in the last decade, right? So the last decade was the hottest. And the frequency and cost of billion-dollar disasters have gone up since 1980. At the same time, data access to be able to track all the stuff that's happening is being dismantled at the federal level. And so this is the moment we're in. And in terms of the health impacts, I think that I think the overview is that health impacts are broad across a spectrum of diseases, across all organ systems, across all life stages, including prenatal. Let me just maybe use an example of heat, because I think that's the one, maybe that's the most familiar. And I think that you can think of heat stress and heat stroke and premature mortality as some of the most obvious health outcomes that we might see. Some of the researchers at our center, and this is all, like, anything I cite is papers that have come out within the last few years, they actually use some health claims data to look at the effects of heat and ozone on heart attacks and strokes. And there is an association, and what's maybe surprising about that data is that that's true even for younger populations, where you might not expect some of those effects. Another researcher from our group, through a pilot grant, looked at data from California birth cohorts and saw that increased prenatal exposure to heat actually was associated with the development of childhood lymphoblastic leukemia. Looking at mental disorders, so again, researchers from our group had data from New York State and saw an increase in emergency department visits for mental disorder episodes. Beyond heat, I think it's really important to think about wildfire. We've talked a lot about wildfires and floods. And from the sort of property, like the PNC, I'm getting my insurance acronyms. The PNC perspective, I think there's been a lot of discussion about that. But I think from the health perspective, I used to work, so I've been working in climate health for 10 years, and I previously worked on air pollution related to coal-fired power plants. So I feel like I know a lot about PM 2.5, because that's one of the major pollutants, most harmful pollutants. And beyond the respiratory effects and the running eyes and that cough that a lot of us experienced in wildfire episodes across the eastern seaboard, across the Midwest, across the West, beyond those respiratory effects, the asthma ED visits, the exacerbation of COPD, there is the cardiovascular effects. So again, heart attacks and strokes, very strong evidence around those increases with acute and prolonged exposure. One of the scariest things that I don't think people know about PM 2.5 is that it is classified as a class 1 carcinogen by the International Association for Research on Cancer. That's the same class as asbestos, tobacco smoke, and UV radiation. So it's very strong evidence. And a lot of these harms come from the size and the composition of wildfire smoke and PM particles. They're so tiny that they not only get into our lungs, but they can enter our bloodstream, which is why they cause inflammation everywhere. In terms of composition, it's what is burned is what is in these particles. And so when you're thinking about burnt vegetation, there's these polycyclic aromatic hydrocarbons that are, by the way, they are also carcinogenic. There's heavy, when they're burning homes and cars, in industries, that's heavy metals, that's loads of plastic. And so that is going to have some really important, serious long-term effects for the populations that are exposed. There's also the impacts on soil and waterways, right? So like accumulation of the food chain. So I think there's a lot of concern around wildfire smoke that may be under-recognized, perhaps in the broad public, perhaps in the insurance industry. I don't know, y'all have to tell me. And then flooding, same. I think there's recognition of the displacements, the injuries, the death at the acute and immediate level. But then if you look at the longer term effects, there's the mold, right? And a lot of sort of like the sequelae of that in terms of skin infections, respiratory diseases, GI issues, mental health impacts. So I think just to sum that up, it is, I think, beyond kind of some of the more immediate and obvious things. And there's this body of research has been around for a couple of decades, but it has matured, it has advanced, and the news is not good.
Well, on that uplifting note, Jennifer, thank you for framing it out for us and how we're all going to fare. And so, Adam, maybe you could tell us a little bit about the data that you collect at the Hartford, and particularly its impact on mental health and what you're seeing among people that you get data from on productivity as well.
Absolutely. And so just one of the other things I wanted to point out that you don't think about sometimes, the supply chains and shortages that occur with some of these events. And so, you know, when we had some flooding down in the Carolinas, we had a shortage of crystalloids, you know, saline solutions, things like that. So surgeries were delayed because of that. So you have to keep in mind how big, you know, the universe is as we're dealing with this. The Hartford, yeah, so the mental health aspects of all of this are real, and what the Hartford really focuses quite a bit on. It impacts everything from the quality of life for the individual. It impacts the employers for their employee retention, prevention, presenteeism, productivity. All of this is important. And there could be everything from fear, worry, and distress that go along with this, as well as the aggravation of any other mental and behavioral health issues. So the Hartford did, in this year, 2025, we have something called the Future of Benefits study. We actually survey the U.S. Employers and employees, and we, you know, ask a number of questions, what workers would specifically like, and employers what they're actually doing. So 60% in our survey, 60% of the workers would like their employers to provide more mental health resources. So that was interesting that was that much. And in addition, employers can improve resiliency amongst the employees by providing a number of things. Flexibility of work schedules, especially around any of the events, things like that. If there's a weather issue, the heat we talked about, but there are other cold events that occur as well. Financial help was one of the challenges that people experience, and so there's a number of ways that employers can help their employees. We've talked a lot about parametric insurances. The Hartford has some versions of parametric insurances, so if there was a cardiovascular event or a cancer or something like that came up, then we have a critical incidence insurance, which just gives the payout if they have that diagnosis. So that's important. But I think more interesting is what's going on in India. And they basically have a parametric insurance through Swiss Re. They're working with SIWA, which is a self-employed women's association. And they basically have a threshold that if a temperature hits 110 degrees there, so pretty high, but that people don't go to work and they get paid. So that's an example, I think, in India that we can take a look at. Obviously, 110 may vary depending on what part of the country you're in, but these parametric insurances, I think, are very helpful. The only other thing I'll mention with regard to our Future of Benefits study is that support in the form of mentoring programs, as well as employee resource groups, and other resources as well. So we can talk more about EAP and other resources that are available as well, employee assistance programs. Thank you.
Thank you. And so, Marie, if you could share with us a little bit the perspective of the state and what you really see the trends are from insurers so far.
Yeah, absolutely. So, well, first of all, when I hear Jennifer talk, I hear costs going up. I've just, a couple of weeks ago, signed off on a 13%, 13.4% increase in our individual market, which is the market that serves our individuals and businesses. And, you know, a lot of the costs, and we're seeing a particularly high jump this year because of the loss of enhanced tax credits that's anticipated, that you may have heard about recently, or may tomorrow. So, but like underlying that, right, like what the costs are that, that are included in major medical hospital policies. You know, in Maryland this summer, we had record heat and humidity for a really sustained length of time. And so we had the highest number of heat-related deaths that we had seen in 10 years. And then, which is just tragic. But then right behind that, when you see that level, those level of deaths, there's hundreds more ER admissions, right? There's hospital admissions associated with that. There's all kinds of health impacts that translate into costs. There's exacerbation of chronic conditions which turn into pharmaceutical costs. And so I think everything we're seeing in terms of healthcare cost trends generally, I think we're talking about seeing those get exacerbated over time by climate change.
So just sticking with that for a minute
Yeah.
with you, Marie, what do you see the role of state regulators, public health departments, as we try to address these evolving health risks going forward?
Yeah. So this is where I'm going to put my insurance hat on and say, you know, I think we as insurance regulators, our role isn't necessarily in that public health and population health sphere generally, right? We are looking at rates, we are looking at solvency, but I think, and you heard from the last panel, and I know we'll talk about a little bit more as we go on, this TFCD reporting and giving insight and really pushing our health insurers to think more about the risks they need to manage for in the future is just really critically important. A couple other just thoughts I have about the role of insurance commissioners and sort of our plans is, first of all, just the importance of keeping in touch with our departments of public health, right, and our public health regulators in Medicaid about what they're seeing. And then just, you know, one of the key roles that we play as regulators is being that addressing emergencies, right? So if there are, for example, we had severe flooding in Western Maryland this past year. We, as the insurance regulator, put in emergency action to make sure that folks could get their medicine without restrictions, right? That we're removing barriers to health created by events that are probably caused by climate change. And so I see that's probably going to increase in the future.
Yeah. So David, how do you think CFOs and health plans should be thinking about this? Should be thinking about the regulatory space and where the private sector meets it?
More. So I think it feels right now like we're in a tale of kind of two very different approaches to this, and I'm heartened seeing more and more that health becomes the center of this conversation. I think it brings the temperature down. I think it makes it a more accessible discussion, and I think sometimes when we've talked about these big climate-related topics, it feels so diffuse to people, but I think when we put health at the core, it is, I think, a value and a set of principles that we largely agree on. And so I think, that being said, there's a set of actors in the industry that I think are still hoping that the regulatory environment compels them to act. We've seen that more in other industries that feel more subjected to largely the European standards. But I'm really heartened to see a set of healthcare organizations, especially in the private sector, seeing that this is now a material business topic. And to the other points that you all have made, the risk and the cost associated with the risk is very, very clear. We've seen studies where, when the ambient heat is over 80 degrees Fahrenheit for 3 days in a row, ER utilization spikes. That's cost. And that manifests in a variety of ways. And so I think there's a set, and there's an opportunity for health plans to really think about not just what they do to manage the risk, but where do they create value? If I had the power, I would be building behavioral health clinics and early cancer screening capability all over the parts of the country that have been ravaged by wildfires. Like, we know it's a very predictable pattern what the epidemiology will teach us, and I think that actually gives us the chance to have an early warning system for where health needs are going to go in the future. And I think if you think about it from that perspective, like, you actually see a set of opportunities to better serve patients, better help communities be resilient, and also, drive the appropriate kind of financial value of the issue.
I think you raise a great point, because at the end of the day, I think it's very tangible where the costs are going to be and where the opportunity is to potentially intervene early. And so, Jennifer, just going forward from there, can you comment a little bit about looking at all of this through an equity lens? Because I think some of what we just heard David talk about too is, where are the risks? where are there maybe gaps in healthcare delivery or access? So do you have any thoughts on that?
Thank you for the question. I've been thinking about this even from the first panel of the day, and really thinking about these upstream, like how do we think upstream? And maybe another framework that, I don't know if you all can picture the Venn diagram of the definition of risk, which I don't know what it is in the insurance industry, but in public health, it's like hazard, exposure, and vulnerability, right? So hazard, exposure, vulnerability, and then risk is like that intersection. And so the hazard part, maybe I'm gonna get back to the hazard last. In terms of exposure, I think there's a lot of opportunity. So I always think of like the Chicago heat wave of '95 as this like telling example that many people are familiar with. And we know a lot of elderly people died. We know that they were primarily lower income. And what is that exposure, right? So the exposure came from the hazard, but a lot of it was because of lack of air conditioning, inadequate air conditioning, people having their windows closed because of street crime in these like lower income neighborhoods. And so a lot of that kind of built environment really exacerbates the exposure, like urban heat island effect, all lack of green spaces, all of that contributes and affects exposure like outside of the individual level. And then vulnerability, again, it's age, it's socioeconomic status, it's gender, it's like social capital, right? Like your public health infrastructure, your mobility, your ability to go stay with a friend, or you're just like housing quality and housing tenure and security. So I think those are, I think if you look at that in terms of risk, I think those sort of tell the story about the levers of action. And I think that for states, like Connecticut, it's great to see like, the insurance department convening this, our health commissioner moderating this panel, and just other Department of Energy and Environmental Protection and Office of Policy and Management and Department of Labor and many departments in the Department of Housing, obviously, most very importantly, coming together to coordinate and to look at this multi-sectorally.
Thanks for that. So, David, I want to come back to you again on thinking a little bit about what levers you think currently could accelerate action on climate and health in the insurance space and in the healthcare sector. How can we better translate evidence and research into driving business decisions and policies? You touched on this a little bit with making the cost calculation evident to people with keeping health at the focus. But if you could comment on that a little bit.
Yeah, I think there's a few ways to think about it. I think there's more to be done on the data and the analytic side. I think you've done a phenomenal job kind of translating the academic public health literature, but I think more needs to happen to kind of bring it from the, here's the social benefit, here's the macroeconomic benefit, into here's the benefit that actually accrues to the line of business that someone cares about, and either at the member or the pop health level. I don't know how you manage a value-based contract without factoring this into the equation. And I've got a kind of simmering belief that, and I'm curious about this, you might actually have the data, how much of the cost of care increases that we're seeing over the last 12 months are actually due to the lingering effects of an underlying level of acuity and illness that we've not picked up in the actuarial data because we've been kind of stuck in some legacy ways of thinking. I think some of it is a coding question, but I do believe that a meaningful amount of the change is probably because through COVID we are sicker than we have appreciated, and climate is playing an important role in that. So I think there's a really important data conversation, and I think the plans are sitting on loads of it. I don't know that they're asking the questions necessary to look deeply into it. I think there's work around what are we actually going to do about it, and I think that's been an area, especially on the clinical front, where I feel like we haven't had clear enough kind of guidance and evidence on how do you change a clinical protocol based on an exposure or an individual kind of level of climate risk. If your 90-day fill is sitting in your mailbox for a week in the sun, does the efficacy degrade? If you're balancing a statin and going outside, what's the trade-off that you're willing to make? And when I talk to physician friends, I don't feel like we always have the guidance necessary to do that. Same thing operationally. We had a discussion last week on climate and health and the youth perspective. Do you close a school on a high heat day? Do you give up the educational benefit because there's an environmental hazard? But how do we start to make some of these trade-offs? I think it's going to be a really important, what do we do based on it? And then the third lever, to me, comes down to leadership. And I think this is a space where we kind of know that we need to do more than we're doing. People want to see more data and more evidence, which is incredibly important. People want to have more clarity on what to do about it. But at the end of the day, I think the leaders, the boards, the executive teams across the industry have a really important role to play. And I'd love to see more, be willing to be out in front, be willing to be bold, and be willing to do what we know is necessary.
So you brought up a few interesting points on data, coding, and Adam, I thought maybe you could just comment specifically on how you think employers and insurers can implement protocols around coding and metrics to make those actionable items real for CEOs who are running insurance companies.
Yeah, the short answer is we have some kind of incentivization type programs. And so we can talk about, is there a decrease in premium, or is there credits, things like that. But behind it all, we need to know what the ROI, impact is going to be, the cost benefit. And so knowing that what's the quality of the data, we have to ask that question first, I think. And so it really comes back to, especially since a lot of the health issues that we're dealing with are coming from the physician data submissions for their bills, the electronic medical records, and are they capturing it? How good are the ICD codes, the diagnosis codes? But we've got other procedural codes that we can look at. We can look at durable medical equipment codes. We can look at other systems. So the National Council on Compensation Insurance has, a coding system that we use in the work comp world, and that can help as well. So we look at all of this, which gives us as a payer, carrier, insight, but again, it's only as good as some of the data that we're getting from the physicians as well. And so the capture of that data, the quality of the data, I think still needs to be enhanced. As I mentioned, I think the socialization of the risks, the conversations that we're having, both economic and the health costs, need to be looked at very closely, because you can have a trade-off. It was mentioned at an earlier session where, what are the health costs and what can the health carriers do to assist in mitigating some of these issues as well. The only other thing I would say is we as carriers with our customers, it's nice if we had a consistency of climate standards that were out there as well. And so if you look, we've got states that have different heat standards and so on, and some may just be specific to one industry. Another might be more for just indoor heat. Another might be just for outdoor heat. So I think all of that and getting, employers a little bit more activated as well is helpful. And then the other thing is, in all the conversations and the research and answering questions, there's a Health Action Alliance that the Hartford's part of, and we have been, developing with Mercer and others a calculator that can show the employers. I think you have to show them the financial impacts and the potential benefit for acting rather than just letting what's going to happen.
So Marie, you heard the question that David asked you in the beginning. I don't know if you have an answer to that in terms of any sort of sense of cost, as it relates to things that maybe have been billed for, but could you give us any information you might have on that, and also just any insights you have on insurer reporting as it relates to this conversation?
Yeah. So the question that David asked, I wrote down here because he said, I think insurers have the data. I don't think they're asking the right questions. Did you say that? The right questions.
That wasn't off the record.
Maybe I translated that.
Yes.
But I think that's like such a powerful insight, right? Because it is what are those right questions to get us to that risk, right? I can tell you right now that, like, at least in our actuarial review, no, we don't have that data, right? But we do have an all-payer claims database in our state where we could start to do some of that work, right? And make sure that we're getting prepared as a state to ask those better questions and get some better answers. I, took a look at our health insurers I'm like, TCFD? TFCD? TCFD. Filings that also sort of indicate, right? Like insurers are thinking about some of their business operations, emissions, but that area of studying, understanding that risk, much less building it into products, is not quite there yet. Still thinking about that. There's opportunity there. I guess the other thing that I would say, and I think, Adam, you touched on this, right? The cost benefit of the intervention. One of the things that I think is challenging for healthcare financing programs generally, whether they be in our fully insured market, whether they be for our Medicaid programs, whether they be for self-insured employers who are looking to understand what the benefit of the intervention is the time horizon of the intervention, right? So for our fully insured markets, depending on the market, folks may have an average length of stay of a year or less. Employers, right? You may pay for something and then someone may switch jobs, or they may go to Medicare and Medicare may see the benefit of the intervention, right? So that's something I think, I know we'll talk a little bit more later on, but I think that's something we're gonna have to wrap our arms around, as well as how in this life and health space do we appropriately incentivize the interventions.
So Adam, I'd like to turn to you now and ask about how you think health inequities can be identified, measured, and used in designing insurance or resilience programs for employees that you have. And what data do you think we need to better model health risks and integrate them into insurance solutions that are created?
Yeah, there's a lot there, but basically, you need to understand the vulnerability factors. And one of the things that we are just starting to look a little bit more closely at, I think, social determinants of health. That really has sometimes the biggest impact on health of an individual. So everything from food insecurity, housing insecurity, transportation access, you name it, there's a lot there. But I think we have to look at that, and then you can see that it's broken out sometimes by demographics. And again, different age groups will have different reactions to certain exposures. Geography is a big part. So do you look at metropolitan statistical areas, or people are looking at counties and zip codes, things like that, but you're able to then focus in where those resources need to be had. So if you're keeping all that in mind, add in all of the medical that was started to talk about, the medications in particular, do they have access to the medications? But if they're taking their medications and they already have access, what kind of risk does that put them at in a hot, warm environment? So I think having all of this and working again at different levels, especially with the employers, you can develop, different kinds of heat illness prevention programs, for instance, if we're talking about heat. And so the Center for Construction Research and Training has put together a beautiful checklist that's out there, and I think getting employers familiar with that and having them put together and develop a heat illness program, that addresses issues around even acclimatization, so the body will get used to it, but the heat, but you need to introduce it to that expose it in a different way, over a period of time, because most of the events of heat exhaustion, heat stroke are occurring, on day one. So, let's get and use some of the things we know about what the body can do. I think there needs to be established trigger conditions for implementing the HIPs as well, the health illness prevention programs, and really have a response and plan in place. So, encouraging employers to adopt these kind of measures will help them, especially if they're, in multiple jurisdictions and multiple states, to be able to identify those employees at risk. And really, the education of the supervisors and the implementation of these programs will be critical.
You know, I think it's interesting from the perspective of somebody in the health department, and those of you who are not from right around here, and you think about I-95, 91, 84, communities that live right off these highways. We know, for example, in our state, a town like East Hartford, right off the highway, that's where our asthma rates are the highest in kids. It is predictable, it's consistent, and it's been like that for a long period of time. And you talk about exposures. And so, you know, Jennifer, as you think about what role academia can play in this space as we try to help think about the gaps and research that can be filled, what do you see academia's role right now?
I see academia's role as being in more of these kinds of conversations to understand, like when you design, even from the point when you design your study and think about the geography and the increment of the exposure that you're measuring, like all of those details I think can be really enriched and refined through these types of conversation with insurers, like outside of academia, basically. I know that attribution science came up in the conversation earlier, so there is a lot going on academically. I mentioned just all of the science along different diseases and life stages, but the attribution science is really getting at what proportion of some of these health outcomes is attributable to climate change in particular, rather than just the association. I think there's a lot of interesting work being done there, looking at, again, beyond heat, but looking at like mosquito-borne disease, like the vector-borne diseases and other infectious diseases, looking at the air pollution and the wildfire smoke, looking at floods. Like I think there's, one of our colleagues did a review of health attribution studies that came out in Nature Climate Change a couple weeks ago, and it was showing that from Hurricane Harvey, the life years lost from all of the effects came out to $17 billion. There's a lot, I think, there related to children and all of the sort of climate-related impacts, I think particularly preterm birth, which has a lot of sort of lifelong consequences in terms of development of asthma and types 1 and 2 diabetes and cognitive impairments. A study in China quantified that at $300 million per year. And so the question then is, right, like how do we better protect pregnant people? And then there's also, of course, the rest of the working population. These are the types of questions that I think academics are interested in these questions, but to the extent that their questions can be further refined, I think really involves these types of conversations.
So, David, you mentioned a little bit about this before, about the business value of actually looking at these data and incorporating it into the models that insurers really look at. How do you think that insurers and providers can act on these data once they're available? And I will just say that my hidden fear is that your zip code or where you live will become a pre-existing condition, because it is in a way. And I worry that insurers will use it in that way. And so I think what we're looking for, I guess from a health perspective, my perspective would be, how can we use it to help move the conversation forward and make the business value of that to insurers without necessarily penalizing people for where they live?
Yeah, well, and grateful to both of you and the types of work that you do to make sure that there is the kind of protection against, where harm can spread inadvertently. We did a study last year estimating that if we got to better health outcomes in America for everybody, basically raising every state to a level that is doable today based on which 10 states have the highest levels of healthy life expectancy, we'd see GDP grow by $2.7 trillion between now and 2040. So there is, I think, a clear business case on how addressing health hazards, health vulnerability, health equity drives the economy, and a meaningful chunk of that, about $800 billion, would flow down to the bottom line for the private sector. We've done the same thing on the cost side. Health disparities cost the country $320 billion. That was a 2019 data point. There's been other studies that put that closer to the $400 or $500 billion mark. That's going to grow to $1 trillion plus by 2030. 2040. And then we've also seen more work around the value of prevention, and this is your point that you keep making about going upstream and preventing illness before it onsets. And I think the belief for a long time has been prevention just delays total cost of care, and it still spikes end of life. And we've done some new work to try and refute that claim and say we actually see an overall lessening of the total cost of care curve to about $2.2 trillion by 2040, which would actually drive the opportunity to really look at Medicare solvency in some different ways. So I think that the numbers are there at the macro level. I think the work for the health plans to do is to translate that to their own areas of focus. And I do think part of that is going to be we're going to have to refute this belief that churn prevents doing the right thing. And I know that is like the prevailing line of thinking in a lot of our conversations. And 9 months on Medicaid, maybe it's 3 years on a non-MA senior. But I think how do we start to get more longitudinal data? The other part that I wouldn't discount is the qualitative data. And I think this is a space where the power of storytelling, the power of narrative becomes incredibly important. And I've been really impressed seeing some of that come through from the kind of provider workforce element. And we sometimes forget that as we talk about the effects of these events on communities, the clinical workforce is part of the community. And the stories that we've seen around, the physician who is driving to the ER to treat wildfire while his wife's on the line saying, what should we save from the house? I think are starting to really kind of change the level of empathy and kind of the human element that we can't forget that side of the data as well.
Thank you. So for everybody in the audience, if you've had any burning questions, please put them into Slido. I've got one more question
happy
for the group.
Too, like
yeah, happy questions are good. Happy questions are good. And we'll try to get to as many of those as we can as well. And so, Marie, I want to ask you how you think insurers support health resilience and reduce the risks for vulnerable populations, because it is the same vulnerable populations that are impacted most by the climate issues that we're talking about right now. So they are communities where there's already an undue burden of many chronic diseases that are only amplified and exacerbated. So what do you see the role of insurers in that and supporting that?
Yeah, well, first of all, even just the coverage and making sure that folks can get their health needs met when they need to and have access to that is incredibly important. I think I would encourage health insurers, first of all, to be thinking more strategically, to be building these climate change and all the things we've talked about today into not only their risk assessments, but in their more near-term strategic plans and thinking about how they can address them. I do know that health insurers, especially depending on the market, have been thinking more over the past 5 to 10 years about non-health related interventions, right? Whether that's, we call that social determinants of health, health-related social needs. Some of the things we've been talking about in a world where the climate is changing are interventions that may not be exactly medical, right? So to prevent heat exhaustion, that might not look like a medical intervention, at least on the front end. To address asthma and air quality in homes, right? Sometimes the way to do that is not just medical interventions. And so I think we need to continue to have those conversations with insurers, as well as make sure that we're all staying connected, again, with our health departments and having that cross-health insurance conversation overall.
And so, Adam, what do you think are some of employers' best practices as it relates to heat protocols, mental health interventions?
Yeah, and again, having that in checklist, having a program that's activated in certain environments, temperatures is important. I think really the mental health aspect and supporting the resiliency of the population is going to be critical here. There's different resources, NAMI, the National Alliance of Mental Illness, and others, Active Minds, and Milken Institute have a number of resources that we can share with our customers, employers can get access to. We also are always looking at potential apps that are available that can help individuals in times of need. And so as we go through all of that, I think the training, the protocols need to be in place so that everyone knows exactly what it is. And the training goes not just from the supervisors, but to all the employees. And so they can also help support a coworker if they're having, you know, some behavioral health, mental health issues as well, so that they continue to stay at work and be productive as they're working through these programs. So that would be the biggest thing. It's policies, procedures, and making sure that everyone's trained on how to use them.
So Jennifer, if you could conclude for us with how community and public health partnerships can help to ensure equitable protections for populations. And maybe you can comment in that context also of how we collaborate through a grant that we have as the Public Health Department called the BRACE Grant that we partner with Yale on specifically to address some of those comments. So
yeah, thanks for bringing that up. So just to start with that, you know, right here in Connecticut, through this BRACE grant, which stands for Building Resilience Against Climate Effects, it's a CDC framework. Yes, the CDC Climate and Health Program still exists. And yes, we did just get our grant renewal. So we are really looking forward to doing the outreach in our final year, final sprint, working with local health departments in Connecticut around their heat and air quality response planning, and really looking at those together because some of the responses are they're overlapping, right? So like when there's an extreme heat event or an air quality event, then you know the traditional solution for heat was and it still is cooling centers. We know that sometimes those are not very well attended, if at all, and they're not necessarily in community spaces. And so one of the mini grantees, they've been looking at building these resilience hubs where it's a community space where everybody is, you know, already like meeting people where they are, they're comfortable, it's very inclusive and accessible, and kind of really listening to and elevating community voices that way. It's, you know, doing like hyper-local air quality or heat monitoring in certain communities to identify those hotspots where there's larger degrees of exposure and really targeting interventions that way. So we're also developing a toolkit so that, you know, not just the pilot grantees, but other health departments around the state. You know, Connecticut, we have like 60 health departments to be able to benefit from some of these best practices that we've compiled from around the country. I know there's more work that your staff is doing around just like the capacity building and getting data from, you know, from the State Department of Health to be able to look at, you know, what that looks like in, you know, extreme heat and hospital admissions, and making that and just building awareness around that, I think is critical. And then a couple of weeks ago, we convened a, you know, well-attended symposium on climate change and health in Connecticut. So even in our small state, you know, I think there's a lot of interest. So more work to be done on that. I think I'm so glad that Commissioner Grant mentioned creative partnerships. So like one of the things that I know for like these wildfire smoke events is that like indoor air filtration is so important, and these can be made very cheaply, or you can buy one, you know, for, you know, a decent amount of money, but like middle and higher income households can afford them. But some of the households that have sort of poorer or older housing quality and don't have air conditioning and have to have their windows open, do not have access to this kind of very basic technology that can really reduce their exposure. N95 masks are a very simple and cheap intervention around protecting oneself from PM 2.5 smoke. Are there ways that, you know, can be just like through employer programs that this kind of stuff can be done? Again, like thinking about the longer term benefits. I thought of a creative partnership. This does not involve the insurance industry, but I was thinking about New York City Department of Housing sort of did like a design competition for induction stoves because those are, you know, have been quite expensive. And so leveraging their economy of scale in public housing, they're, you know, encouraging people to create a cheaper induction stove that then can be deployed and really, you know, helping reduce that indoor air pollution and reduce greenhouse gas emissions. I would be remiss to not say something about greenhouse gas emissions. I know that may be the elephant in the room, but we are at a climate risk conference. And I think that for me is the mitigation. I know there's other definitions of mitigation. And I know insurance, there's like, on this like the risk management side, it's different than like, investments. But I do think as in the insurance industry, as health professionals, as the health department and the housing department, I think there is a role to look at and to call into question the idea that we can't do anything on the climate mitigation side of things. I think the more that we can talk about these effects and the costs to health, to our economy, to businesses, and to economic prosperity, I think that really hopefully helps strengthen the case for action on climate mitigation. So I will just leave it at that.
Thank you for that, and I think you do nail it on the head, because part of what we do in public health is educate. That's actually what we do a lot of. It's probably 50% of what we do, I feel. And to the point on reducing greenhouse gas emissions, we were on a panel, Jennifer and I, last week for Climate Week, where I talked about Revolution Wind and the fact that that project with windmills in the Long Island Sound, $5 billion invested into it, 80% of the work done, was shut down because the federal government decided to cut $550 million left, and through a lot of collaborative efforts and the administration suing, and the project is off and running again. And so again, if we can talk about these things, we don't know if that's the conclusion and if it'll get done, but we hope so. That is going to have tremendous health impacts in terms of our state. 350,000 people in the state of Connecticut will be able to get wind energy. That is going to drive down greenhouse gas emissions. So we have to continue talking about it to potentially be able to also help influence those other levers that we don't necessarily have directly in the health department. So I'm going to take the privilege as the moderator for the first question here, since it seems to be directed mostly at me, which is, does the public health department have a heat map of the state showing places where asthma and other environmental health conditions exist, just like we do for floods? And what I would say is, part of that is the work that we've been working on and developing a little bit of for the state and collaborating with Yale on. I would also say that in general, if you think of our cities, when there's a heat wave, Connecticut's a pretty small state. In general, the areas that have less shade, less cover, more factories, we tend to see the heat impacts greater in those areas. But we've seen that also in so the valley area. There are areas where the air quality is bad based on different factories that may be out there. And so that's part of what we're continuing to work on and develop. I want to go to the group, and anybody can feel free to take this question. What opportunities do you see for different groups to collaborate and help fill the gaps in climate change health impacts? Anybody want to take that?
I'll start. I mean, basically, I think having multidisciplinary approach, getting the different perspectives in the room, really understanding and expanding from a standard cost-benefit analysis, effectiveness to a value proposition. So if you have employers in the room or you have other interests, they can look at what their preferences are. I think we need to understand that there are different ways to approach and address each of these issues as they come to us. The other part of this is bringing economists in. I have study groups with economists all the time to help me figure out, as we expand and talk about value propositions, looking at what's the process and effort for doing this. Is there a different way to do this that's more efficient, less costly, less of a process issue? I think those minds have to be at the table as well. And obviously I'd bring in prevention services, so risk engineering, so the industrial hygienists, the ergonomists, all those that are out there that can help with regard to preventing the illnesses as opposed to trying to deal with them after the fact.
I think we need more diversity in the conversation. I think a lot of us were at Climate Week last week, bigger than ever before, incredibly energizing, but sometimes it feels like we're with slightly different panels and the same topic of conversation. And I was really excited to see more and more kind of truly cross-industry, cross-sector conversations happening. How does food and nutrition relate to the environment, relate to health? What's the role of innovation in universities and technology in solving some of these? But I think we've got to get comfortable inserting health and using health as a lever into broader conversations and avoiding the comfort that I think sometimes comes with this space.
I would love to, I would love to just quickly piggyback on that with the diversity comment. And I was just thinking about, like even within Connecticut, it's quite, there's different pockets of diversity. So we have like quite well-off suburbs in some cases, and then we have like some of our cities that really struggle with climate impacts and then all these layered environmental harms. And environmental racism through decades of housing policy and economic policy. And those voices are really important because I think they obviously are seeing firsthand what the issues are, and they're also going to be able to know what's going to work and what's not going to work. And also, who do they trust in order to learn about, to even just like gain the information. I don't know that Yale, we've been trying to, be really collaborative with communities, but there's still a little bit of that, you guys are ivory tower, who are they gonna listen to? Oftentimes it's community leaders, it's faith organizations, right? It's like they're, doctors and nurses, and other trusted groups who are community groups, community health workers. So who are at the front lines in working with these kind of, quote unquote vulnerable populations? Because oftentimes you'll find that they're vulnerable only because of their circumstance, but oftentimes there's a lot of great ideas, they have agency, and I think they should be a vital partner in a lot of this, looking at the solutions.
Yeah. David, maybe you can take this question. What could the role for nonprofit health systems and hospital community investments be in driving investment in healthy communities? And do you think that they are under-leveraged?
I think they're under pressure. I think there's a lot of pressure facing the provider sector, especially the nonprofit one at the moment. And I think it's a continuing challenge to get people to recognize that this is a clear and present threat in the face of a lot of other things that feel like clear and present threats. But you go back to, and I think you mentioned this on the academic point earlier, oftentimes, the nonprofit health center is the largest employer in the community. They're often at the front lines of seeing the impacts of this issue up close and personal, and their providers are deeply connected to the community. So I certainly do think there's a greater role to play. And I also think it's an area where more collaboration is an exciting opportunity. And I think there's a lot of room to come together. There's already wonderful coalitions. There's an insurers working group that Healthcare Without Harm sponsors. There's similar things with the Healthcare Anchor Network on the AMC and on the hospital side. But I do think coming together, and back to the data point, again, like we're sitting on loads of great information from the community health needs assessment processes that they all have to do every 3 years. Like we're not leveraging that enough to drive the change that we need.
Can I respond to that
Sure.
just quickly? Just to give a little plug for Maryland, because we actually have a unique all-payer hospital model where I think it's not perfect, but there's still plenty of important work to do, but the incentives are changed. Our hospitals are paid by global budgets, and so that they are rowing more in the same direction as insurers, I think, than in other places. And so that, not easier said than done, but that is one way to think
Many
about
of us envy what you have in Maryland. I will not deny that. Maybe you can also comment on a potential role for insurers in covering access to, it says here nature prescriptions, but maybe it means natural prescriptions also, as part of a holistic approach to conservation, or nature prescriptions, I guess.
Oh,
actually.
I'm forgetting the term, but like going for a hike.
Yes,
right?
I think so.
Nature
I think
bathing.
that was that's how I take it. Yeah.
Yeah, that's a great question. I do think, again, to this conversation, the role of insurers, encouraging insurers to be more creative about all of these kinds of things, that's a great example. But it's also an example where sometimes an insurer's role may be to just outreach and education, right? They do have access. They're going to be one voice. They might not always be the most trusted voice. But I do think our insurers, some of whom have been very creative already, can play a greater role in that kind of thing.
And I'm going to have our last question go to Adam. Adam, if you could take this one. Are there policies physicians or hospitals can advocate for or ways to partner with insurers?
Absolutely. I think the conversation needs to continue. I mean, we do have different avenues of connecting, but sitting down, one of the things I'll say is, you know, the reimbursement system in the US, I think we need to look at it a little bit differently. A fee for service, you heard about the global payment. I think it was Pennsylvania and Maryland that CMS saw huge savings based on that and just said, you're responsible, the hospital system, you're responsible for all these people in your catchment area. And they came up with all sorts of systems and abilities to take care of those people. So we need to, you know, really expand our bundled services is one way, but there's other things out there as well. So outcomes and other measures, I think that would be where the best conversation would have, is not just understanding the data that we need, the quality, the fact that they need to use these specific codes when they are available, but also how they're going to get paid for certain activities and not be at risk. You know, there is some risk in some of these models, but most of the time we can work beyond it so that the health system, the doctors are still able to cover all their costs and be profitable.
So I think with that, we will wrap up this session. I want to thank all of our panelists for really bringing forward different perspectives and views into this really interesting conversation. I think we can all take from this that we all register what's happening with our climate and in our environment to directly impact the health of people who are insured by plans, that we know we are currently in an environment where there may not be specific moves from the federal government to necessarily support climate work per se, but there is an opportunity and there is agency that we all have to be able to recognize the challenge that we have. And I think what you've heard from all our panelists is there's an opportunity to collaborate, to have people from different sectors come forward in this conversation. I think this panel is a perfect example of that. And from people from all different views of life who are all working to a common goal. And to me, that is something that we can be hopeful about and think about how we can continue to do this work better as we move forward. So thank you very much for listening to us today.
Well done.
Thank you so much once again to the panelists for a really fascinating conversation on reshaping the health impact of climate change and insurance solutions. At this time, we'll transition a bit. Before our next lightning round, I'd like to introduce a speaker for